My name is Christopher Shulgan. I'm part of the team that creates content here at Medcan. So next week, October 20th, Tuesday at 12:30 p.m., we have the good news on COVID-19. We're pretty excited about this one. It's one of the rare good news stories of the pandemic. Proportionally fewer people are dying from COVID-19. Fewer of the infected are being admitted to intensive care units. In this complimentary webinar, Dr. Peter Nord interviews Dr. Andrew Baker. So who is Dr. Andrew Baker? He's chief of the Department of Critical Care at St. Mike's Hospital. And more to the point with respect to this webinar, he's the incident commander of the Ontario Critical Care COVID-19 Command Center. So he's one of the people managing COVID in Ontario. He's in charge of that. And he is going to talk in an interview with Dr. Peter Nord. He's going to talk about what the first wave can teach us about better navigating the second wave. So to register for that, go to bit.ly/medcan_good news. Okay, I think it's 12:30, so let's start this one. We're going to do a webinar about explaining the annual health assessment today. It's presented by Dr. Peter Nord. Dr. Peter Nord, how are you?
Doing great, Chris. How are you today?
I'm great. I will just quickly go through your bio. Dr. Peter Nord is Medcan's Chief Medical Officer. Previously, Peter was a VP Chief Medical Officer at Unity Health Toronto, and he's the founder of Stillbrook Accessible Retirement Residences, a registered charity focused on developing affordable retirement living communities for lower socioeconomic frail seniors across Ontario. Anybody who would like to ask questions, please use the Q&A function at the top, and we will get to the questions later on today. So, Peter, why don't you take it away for this, and we can intro the annual health assessment, and then we can talk about the history and some of the reasons why we think it's so compelling.
Yeah, happy to, Chris. Thanks. The annual health assessment has been the core of what Medcan has offered as a service starting 30 years ago and continuing to today. This year, we anticipate that we'll do about 20,000 annual health assessments. So it's a service that's in great demand and has been consistently. Even during COVID, when all essential services had to shut down, we had a tremendous amount of interest in what we could do even virtually in people's homes through various media, video links. And so there, even at that point, people were wanting to have the idea of an annual health assessment. Many of our clients come back year after year, and that provides a really interesting trend line. So as our year to year, as our results come in, people can see, how is my cholesterol this year versus last year? How's my weight? How's my body composition? I've been working at it really hard this year, and so I now can see the fruits of my labor in objective data. So a fantastic report that comes out as a result, and many of our clients really appreciate the time, the comprehensiveness of the assessment, the reports that are generated as a way to ensure that they're doing the best they can for their own health. Just as the slides shows here right now, the effectiveness of the annual health assessment is one of those reasons, is again, that people keep coming back and back. If it wasn't one of our clients, it'd be one of their clients' friends that are also clients. The stories about us finding things early. And so if you find something early, obviously it's better for the person, it's better for the health system, because finding things late costs money to the healthcare system. So that impacts all taxpayers at a time when we are sorely challenged with coming up with the excess dollars to fund our healthcare system, our publicly funded healthcare system. And when you look at the annual health assessment, again, out of the 20,000, 74% of our clients had at least one unrecognized risk factor. So that's something, maybe they didn't realize how high their cholesterol was. Maybe didn't realize how high the blood pressure had maybe sneaked up. 36% of our clients had at least one unrecognized condition diagnosed, so an actual diagnosis. And 6.8% were diagnosed with a serious medical condition. We had 179 cancers that were picked up very early. And again, theoretically, these are lives that we're talking about. People that, on the one hand, The annual health assessment is focused on lifestyle, it's on longevity, it's weight management, stress reduction, performance improvement. But the other end of that spectrum is individuals that have an illness that was unrecognized. And because of the annual health assessment and all the testing, we've been able to discover something that was just lurking and maybe would have taken 5, 10, 15 years before it would have come to the surface. And at that point, it would have been really serious and potentially life-threatening. So there's some of the takeaways to the annual health assessment.
Fantastic. Thanks for that, Peter. Let's talk a little bit about the history of, I'm just going to stop there. Let's talk about the history of annual health assessments and what originally were known as executive medicals. So let's talk about why they were called executive medicals at first and how why we like to stay away from that term, because, well, I'm answering the question that I'm posing to you. So I'm going to throw that to you.
Yeah. So for many years, in fact, those first years that Medcan was open, the focus was really on executive medical health evaluations. And it was said executive because, well, we're downtown, a lot of executives here, and needed to have that sense of my lifestyle. Like, how am I doing? How could I improve? How could I, help me with smoking cessation? How do I manage my stress at work? How do I manage my life, basically? And most of the people, in fact, probably 100% initially were executives, sort of air quotes executives. A number of years ago, I'm going to say probably about 15 years ago, Medcan really stepped away from that and really became a comprehensive, holistic health organization that has a number of services, many programs devoted to the clients that we serve and all aspects of their health. So really, Medcan these days is more of an ambulatory care center offering urgent care services, dedicated care, family practice, primary care, all fitness, the specialty services that we offer, cardiology, orthopedics, sports medicine, rehab programs, women's health, men's health, in addition to the annual health assessment. And so it's much more than it was when it started. It's grown considerably. And with the first couple of doctors starting, we now have 90 physicians on our medical staff providing all sorts of supports for our clients.
90 physicians. That's crazy. Some of the numbers boggle the mind. But let's talk about one of the objections to the AHA, which comes up a lot when we hear about newcomers coming in to Medcan. And the AHA is available to anybody. Anybody can come in and get one. So the idea is that that doing these extra tests, or one of the objections that we hear is that doing these extra tests are unnecessary for some reason, because the people talk about the false positive issue. So can you talk about that, and then you disagree with that line of thinking and explain why?
Yeah, I really do, and I actually got that personally. So when I told colleagues that I was coming to Medcan, I had some colleagues saying, "Wow, that's amazing! Like, great care." And I had some colleagues that said, "Bad medicine. All we're doing is finding false positives and adding cost to the healthcare system." I was pretty shocked by that, because for many studies over decades in many countries, the OECD countries specifically, have shown that preventative healthcare pays way more. The return on investment is significantly more on preventative health than it is on sort of what I call reactive health. It's just that our healthcare system, financially challenged as it is, each province has slowly backed away from prevention, and because of time and fiscal constraints, are really forced to deal in the reactive mode. So rather than finding and preventing cancer, we're dealing with cancers in the moment because that's what we have to deal with. And gradually, the whole prevention aspect has really been, it's actually been delisted. So it's not even paid for through OHIP in Ontario anymore. And so one of the things that we come back to is the idea of guidelines. And so, Medcan Do we follow all the guidelines? We do, and then some. So guidelines are developed by societies, medical societies across a country. So in Canada, the US, other countries, we strike a task force. The task force looks at data and incidence and prevalence of a disease. So if I'm going to take sort of breast cancer and mammography as an example. So in Canada, over time, the recommendations have changed. So 15 years ago versus 5 years ago for this year, they've all changed over time. So you have to take that also with a bit of grain of salt. But in Canada right now, women between the ages of 40 and 49 are not recommended to have mammography. At 50 to 69 years of age, it's recommended to have a mammogram every 2 to 3 years. In the US, they agree, 40 to 49, not recommended to have a mammogram. At 50 to 69, annually, as opposed to every 2 to 3 years, and maybe as you get older, every 2 years. Other countries around the world will say have a different recommendation around different age groups. So in some, it's 45 to 49. They want to have an initial mammogram, at least a baseline check. In other countries, 50 to 69, the age group, they recommend annually, like every single year, having a mammogram. So right away, if you have all these different recommendations, are any of them absolutely true? And so one of the things that we have to think about, recommendations are looking at a population, not at an individual. And at some point, the recommendations will cut a line off. So under 40 to 49, do we have women that are having breast cancer? Absolutely. In fact, if we look in Canada, under the age of 30, 1 in 200 of all breast cancers are in that age group. So 0.5% of all the breast cancers would be under age 30. So right away, we're not going to ever get those women seen. So we're missing those breast cancers. If you look at the age group then of 30 to 49, so again, remember recommendations out there, guidelines, don't do mammograms. 16.3% of all cancers are in that age group. So when you add the two age groups, you have 17% of all breast cancers are in the under 49 group. And again, we're recommending we don't even mammogram those individuals. So right away, like 1 in 5, 1 in 6 breast cancers we're going to miss because the guidelines are starting at that age 50 and up. And even the American Cancer Society has said women age 40 to 49, again, we're saying don't even do mammograms, have a lower risk of breast cancer than older women. Not saying it's zero. There's still lots of breast cancer that's in that younger group that they're not really even checking. So at Medcan, we actually start mammograms at age 40 because we want to actually pick up more of those breast cancers that are picked up and not picked up, whether at their 40 to 49 age group. So we are actually picking up on a big part of that 18%, that 17% of the breast cancers that other people are missing. And as a result, we're saving lives. Now, having said that, are we getting some false positives as a result? And that's always the argument, that we're going to be finding all these false positives, which is going to create worry for the women in this particular situation, cost to the healthcare system as they have further testing done. That, most of the women that I've spoken to, my own patients, have said, I'm willing to have a bit of nervousness around that, but I need to know. I need to know for sure as an individual and my own personal. I don't care about 100,000 women across the province, across the country. I'm worried about myself. And in my situation, maybe I have a family history of breast cancer that makes it more likely. If I see a little calcification or something, I really want to know what that is. And I don't care if it causes me a bit of anxiousness as I'm working through that. And so for sure, there is a false positive rate, but there's also a real positive rate that we don't talk about as much. And if it's somebody I know, if it's my patients, if it's my wife, it's my mother, I want to make sure that they're the ones that are getting the best possible care. And I'll take a couple of false positives to get the actual positive to know if that's in one of my patients or in someone in my family or friends. So that's where this idea of false positives, every time you hear false positive, say, well, okay, how many false positives to actual positives are there? And if we can pick up on something very early with, say, a mammogram, rather than late, in the true positives, what are the savings to the healthcare system? They're massive savings to the healthcare system versus the low cost of an extra test to confirm that, in fact, it was a false positive. So that's kind of the short version of guidelines. They were developed. Guidelines were developed because taxpayers can only pay for a certain amount of tests across a province, across Canada. And so in many cases, guidelines have at their core a certain degree of fiscal constraint applied to them as opposed to medical constraint.
I think of it, so you get the guidelines and that's due a lot of times to the fiscal realities of what we can afford to provide in terms of preventive care. And then we approach it from a different way, which is, what is the gold standard? What is the absolute best way that we can look at this? What is the best preventive measure that we can do annually that provides somebody with the overall best sense of their overall wellness and their overall immune function? You have an interesting experience as it pertains to pancreatic cancer, a false positive anecdote of your own. Do you want to talk about that?
Sure. So my own personal experience. So my paternal grandfather passed away of pancreatic cancer. My father died of pancreatic cancer. I was being screened, an ultrasound, just a regular abdominal ultrasound, finds, guess what? A 2-centimeter mass in the head of my pancreas. So it's pancreatic cancer. So what do we do next? Well, we have to do a confirmatory test. So we did a CAT scan, and it confirmed, yep, it's not good. Peter, I'm sorry. You got to have surgery and chemo, and your lifespan is now 6 months to 3 years. So pretty bad and pretty bleak. So we go one step further, and we got an MRI of the pancreas. And we had some specialists look at it and realize that it was a benign tumor. It wasn't a malignant tumor. And so actually, at the end of the day, I'm still here. We're watching this benign tumor. And at the end of the day, you would say, well, that was the ultrasound that started this whole process was actually a false positive. And that the CAT scan and the MRI were unnecessary tests that was done through the publicly funded healthcare system. And I said, well, yeah, but I didn't have surgery. I didn't have chemo. If I had gone for surgery, they would have had to swallow hard and say, "Oh, sorry, Peter, we took a look, and in fact, the biopsy came back as negative, like the pathology it's benign. Sorry, but now you don't have a pancreas, and you're missing a part of your stomach, and you're now diabetic, and for the rest of your life." So there's a personal example that I can convey that would say, if you looked at it at one point, you just say, well, it was a false positive. It picked up something that, that wasn't really a big problem. And the system paid for a CAT scan and an MRI. At the end of the day, the system didn't have to pay for surgery, for chemo, for rehab, hospital stays, all that. So that's a perfect example of, and a personal one, of how I kind of weigh these two things together.
The false positive argument has always struck me as, it's regulators saying, well, we don't want to let the little people, we don't want to give people the sense that, oh, maybe they do have something and then they're going to worry about it. But I would rather know. And also, if for a little bit, if there's like 2 weeks where I think everybody just kind of balances that in, that, oh, maybe it's a false positive and we're going to get some additional tests and figure out the confirmation of that. Okay, well, this is great. Well, let's talk about the brass tacks. Let's talk about the details of the annual health assessment. And I am going to share my screen once again, and we're going to advance the slide into, so Dr. Peter Nord, why don't you walk us through the various steps of Medcan's annual health assessment?
Yeah, so typically it's about a 5-hour day. Individuals come in fasting or not fasting. We typically get their blood drawn very early. One of the benefits of the annual health assessment is we have a full certified lab on site. And so that means that for the most part, it's one-stop shopping as part of all the core services as part of the annual health assessment are done really on one day. And because we have our own lab, the lab results, all the blood samples, the urine samples come back within about 90 minutes. So if somebody's coming here at 8 o'clock in the morning, they're registered, they're welcome, they can change in the locker room. They're typically moving around 8:30. Ideally, we'd like to get the blood sample taken relatively quickly, so that we by 8:45, 9. We also like to have an abdominal ultrasound done fairly quickly, especially if they've been fasting. And then typically they'll see the physician. Physician will do a comprehensive history and physical, so looking at their past history. What do they want to focus on? What are the primary concerns that the individual may have? At that point, the person then has a comprehensive physical examination with the physician, and then goes through a series of stations. And we'll go through these through the slides. At the end of the day, just from a timing perspective, all of those results come back in real time. So you don't have to come back days later. It all comes back. The physician has all this information at her or his fingertips. And so when the person comes back at the end of their day, I literally share the monitor. I have a monitor, I turn the monitor so that the patient and I can go through together all the results that came in, and then some recommendations. We create a treatment plan, recommendation plan. It all goes into a package within a few days after the person leaves that day, and they can check it on the My Medcan portal. And all of that information is available to them. And again, for many people, this may be the third or the fourth or the 10th time they've gone through the annual health assessment. And we can show today's results compared to last year's results, compared to the year before that, and literally show trend lines in where things are going. And they're hopefully in the right direction. If not in the right direction, we need to do some countermeasures and some course correction to get them to back on track to becoming as healthy as they possibly can be. So that's sort of how the day progresses. There's typically a bit of a wait between each station. We try to minimize that as much as possible. We have food and beverages while people are waiting. And even these days, I'll put a plug in for our teams that have done an amazing job during COVID with all the safety measures that are in place. The physical distancing has just been incredible. We've redesigned our entire 15th floor here at 150 York. And as a result, it's very spread out. We don't have more than a couple of people in each lounge as they're going through their day. And so that's something that's been critically supportive. PPE, personal protective equipment, worn by everybody. And we're really lucky at this point. We've had no positive cases associated with Medcan at all. And our physicians are happy, and because they feel safe working here as well. So that's what the day looks like. It typically people move through. As the previous slide, they different areas that we're looking at, whether it's disease, whether it's body composition, mental health, stress management, nutrition. So we have a 45-minute to an hour section with a nutritionist to focus exactly on what areas you think you would need most. Stress testing, cardiovascular risk assessment, all of these things come together. And this slide, this is our kind of first station to review the overall health. We're really looking at the high level and what areas are we going to be focusing in on. I think the next slide will go into the next section. And age-related, very specific things like cardiovascular health, bone health, bone mineral density testing, a 12-lead ECG, exercise stress testing. We're going to be starting some very innovative blood samples that will be able to pick up on cardiac disease about 10 years before it gets manifested in other ways. So lots of interesting work in terms of respiratory function, blood pressure checks, cardiovascular health. And then specific disease screening, the lab panel, the blood and urinalysis is very, very good at picking up any sort of diseases very, very early. And then back to some other specific things, hearing, vision, breathing. Again, that rolls back into the overall health review. Fitness, important to have an understanding of the person's overall level of fitness. Again, interesting to see how fitness can change year to year to year. Fortunately, most of my patients, when they're coming through, I'm seeing an improvement over time. So they, even if the annual health assessment is a bit of a motivator, it's probably some value there too. Like it's something that says, yeah, I'm really going to watch my diet more this year. I'm going to work out a bit more if I possibly can. It all and it makes you feel kind of good that you've come in for the day, and either a reward for work done already or a bit of a pat on the back for work that needs to go forward as well. And we're here to support with any number of programs as the year goes on between annual health assessment and annual health assessment. So all these things, body composition, very, very important. And again, I mentioned nutrition. That's a key part of all of our wellness. So that's another aspect of the day. It just goes on and on. It's amazing we can put it into 5 hours. And again, as I mentioned, mind health, the stress management, stress assessment, mental health issues, depression, anxiety, especially during COVID over the last many months, the stress that we're seeing amongst our clients, our patients, is really significant. And we have a whole mental health program here outside of the annual health assessment that we're growing dramatically because the needs are so great. And then we have things that are gender specific, things like PSA testing. We talked a little bit about mammography, breast ultrasound. We can do all of that on site. Pap smears, bone mineral density, all of that can be incorporated as part of the annual health based on your gender. And this is I kind of like to think about the annual health assessment as the core of a lot of different service offerings that we have at Medcan. For many people, the entry to Medcan comes through the annual health assessment. For other people, it comes through other services. Increasingly, people are attracted to Medcan for actually the non-annual health assessment services that we offer, and they sort of back in and find out about the annual health assessment. But historically, the way into the system was through annual health assessment, and then based on the assessment, we recommended either some specific add-ons that can happen during the day, like genetics testing, liver health, dermatology. We can do same-day dermatology assessments, a more detailed cardiovascular risk assessment in addition to the regular cardiovascular assessment as part of the annual health. And then that would be the day. And then other services, like I mentioned earlier, all these different services that we're offering now at Medcan, that wouldn't be the same day. That would be on follow-up days. But these are all available, and they can all be triggered, really the need for them triggered through the results of the annual health assessment.
That's fantastic. Peter, what about the future? So I know you are part of the team that constantly evaluates, are these, are we cramming into this 5 hours the full slate of tests that reflect the most up-to-date and most current evidence base on, making this the gold standard? What are you looking at in future in terms of what you'll include in the, in let's say in 2030, in 2040, what are we getting as part of the annual health assessment?
Yeah, I don't think we're looking that far out, but like, as you said, we're looking sort of month to month, year to year, and every year for sure, we do an update. Are these tests the right tests? We actually are just in the process right now of updating the lab panel. So the blood tests, are these the best blood tests that we can do? And so on an ongoing basis, we check with our physicians that are looking at these results saying, that was great, but if I only had a fixed time or a fixed amount of blood, I would rather have, this test for my patients versus this one. So we're constantly tweaking to make sure we're leveraging the latest and greatest that's out there. Genetics is going to be an increasingly important part of the annual health assessment as we move forward over the next couple of years, as opposed to an extra outside the annual health assessment that many clients are taking advantage of. Really, the future belongs to marrying the data that we're collecting with the genetic data. So the medical data from the annual health married with the genetic information, And together, that's called precision medicine, which is something that Johns Hopkins and our partners in the States at Mayo are really doubling down on in terms of the future. So precision medicine is really taking the trial and error out of what we do. Let's try this antibiotic. If it doesn't work, we'll try another one. As opposed to with precision medicine, we know exactly ahead of time which antibiotic is going to work in you. So there's less trial and error, less waste, fewer side effects, those kind of things. That's what precision medicine is about. And that's what we're really excited to be looking forward to over the next couple of years, really embedding that increasingly in the kind of service offerings that we have. So we're constantly looking at what's out there. We're scanning the research, the latest and greatest that has been evidence-based. We're not going to do something that's fly by night. So if it's been proven to be helpful, and we look globally for what's happening around the world and incorporating those as best we can into the latest refresh of the annual health assessment. So if people are coming back year to year, they'll be coming back, which is great. And then they say, hey, that's a little different from last year. And there's a real reason for that. One of the things we're looking at, just to kind of lean into the whole eat, move, think philosophy, is a very specific annual health assessment that focuses on eat, move, and think, and for different age groups as well. So that's something that we're looking into, and maybe in the future, on one year be the traditional annual health assessment, and in the following year it would be the eat, move, think annual health assessment, and then back and kind of every second year get into a cadence of that. So there's lots of stuff on the horizon, lots of interesting things. So if you've seen one aha, you've only seen one aha.
With respect to the genetics and genome sequencing, how far away are we from including a sequencing of the genome at some point within one of those early annual health assessments? Like, is that 5 years away that it'll just be standard, or what's your best guess on that?
Yeah, it's actually good. We're working very hard on this right now behind the scenes. So I would hope that within a year, actually, we're going to start to offer the gene sequencing. It would probably be an exome as opposed to maybe a full gene genetic profiling. But one of the things that's happened is the turnaround time, the ease, the technology, and the cost of the technology has really become much better than it was in the past. So now this has become a reality for us where we actually can offer it as part of the package. So it's really leveraging local partners. We're not going to be partnering with organizations that do genetics in the States. We're actually looking to partner with some organizations that are in downtown Toronto that are experts in this area. And so it's a result of looking for this information, the pricing coming down so it becomes affordable for everybody. And so that really, I'm hoping that by this time next year, if you come in for your annual health assessment, that'll be a big part of it.
Can we talk about COVID? I mean, it seems like everybody for the last 6 months has only been talking about COVID, but as it pertains to the annual health assessment, and so I think there are two camps where some people say, well, this is exactly the best time to get the annual health assessment because it provides you with an idea of how strong or how of your overall wellness, which in turn is proportional to how well you can fight this coronavirus infection off. Others are nervous about doing anything in person. Where do you fall in that continuum? And what would you say as it relates to the immune function testing with respect to COVID?
Yeah, so, well, for me, I guess I would look at the data and, coming out of COVID, we had to scratch our heads and kind of go, yeah, is this going to be driving more demand or in fact, less demand? And as it turns out, it's actually the former, thankfully, for us, because we have this fantastic service to offer. And the message, I think, has gotten out. We are now booking well into December and January for our annual health assessments. So we are chock-a-block full October. We've got a couple of slots left in November, and then we're looking at really Christmas time. So there's actually a waiting list to get in these days. So I think that's probably the best answer in terms of, is there a need? There definitely is a need, and people during this time period are now especially concerned about their health and their overall well-being. At some point, most of us over the next couple of years are probably going to come in contact with COVID one way or another. Maybe we'll have a vaccination they'll mute our response. But for many of us, if we fall into any of the risk categories, that's going to determine how well we're going to do. Are we going to be asymptomatic, a minor head cold, a bit of muscle aches, like a flu, or is it something that's going to land us in the hospital? And for our clients, we want to make sure that they're in those earlier categories, not the later ones. We want to keep people out of hospital, keep them out of the ICU, keep them off a ventilator. And we know, as we're learning more and more about the virus, and we're actually going to hear about this from Dr. Baker, I believe, that the one thing that we know for sure is the number of comorbidities, so the number of illnesses that a person has, directly ties into how poorly or how well they're going to do if and or when they get infected with COVID-19. So our job then is to control these illnesses, minimize them, keep people as healthy as possible, try and make sure the immune system is firing on all cylinders, so that when that eventuality happens, when eventually we may be all connected with this virus, that it's a non-issue as opposed to something that's really significant. So that's where a lot of our attention is being paid and focused on right now.
Okay, I think we're going a little over, and we do try to adhere to the 30-minute short and sweet webinar rule. But we have two more questions that I want to discuss. So somebody's asking about false positive stats, and are we able to disclose the number of false positives that we had in 2019, 2018, 2017? Is this something that you want to talk about offline, and then I can provide an answer, or do you have these at your disposal?
Yeah, I don't have them at my fingertips, and they're very difficult to monitor, because sometimes the false positive, again, like I'll use my own personal situation. It took weeks and sometimes months to find out if something's actually a false positive. So to bring that back in and trying to collect that data is really hard. We are looking at a research project, though, where we look at the false positives versus true positives and the economic impact of each of those arms. So the only way we can do that, to do a proper assessment, is to do it as a research study and a go-forward study. So, and we actually are going to be doing that.
Next question. Does Medcan have any plans to expand to other provinces? If not, do you have any affiliates or recommendations for similar organizations in other provinces, particularly British Columbia?
Yeah, well, thank you for the question. In fact, the answer is a very much yes. We are currently looking at different sites in Ontario, and more to follow on that, but very exciting. And we also have early discussions with having Medcan in different provinces. Quebec, Alberta, and British Columbia are the leaders right now. We already have strong connections in those areas, and so stay tuned, because as Medcan has become digital, and not paper-based, it allowed us to be able to spread. So we're very excited now that we can do virtual medicine much easier than we could a couple of years ago. It allows us to be able to spread and provide that same high quality of care that everyone expects from Medcan, and to do that at various sites, not just across Canada, but globally.
Fantastic. Thanks very much. I am going to walk through the final bit of this presentation. So next week's webinar again is with Dr. Andrew Baker. It's Dr. Peter Nord interviews Dr. Andrew Baker, who is the incident commander of the Ontario Critical Care COVID-19 Command Center, on what we learned from the first wave and its good news, and what that means for the second wave. If you have questions, email me, Chris Shulgan @medcan.com. Register at bit.ly/medcan_good news. And then podcasts, our weekly podcast. We post new episodes every Monday. Our episode 35 is one of our most intriguing yet. It's the argument against lockdown with Harvard Medical School biostatistician, that's tricky I had to rehearse that, biostatistician, Martin Kuhldorf. Thanks very much. Dr. Peter Nord, thank you. Attendees, thank you for attending. And we look forward to seeing you next week. Have a great week.